Thanks for sticking with me. Welcome to session 2. If you remember the diagram of the grief hematoma, where 80% of what we have in terms of our woundedness is below the surface, and it needs to be evacuated. But before evacuation can occur, we have to identify. That's the first part of the I3, identify, intensify, Iomani, the identification. And translating things from the physical wound care, I like to take their language and actually modify it and use it. So, one thing they look for in wound care is hypergranulated tissue, where there's too much tissue growth, where it rises and it pushes above the wound edge, preventing a proper healing. Well, there's times where when we are talking about, we're just fine, or we're okay, or we get super spiritual in how I describe it, there's a hypergranulated spirit, where the spirituality side of a person, or the spiritual side of a person, grows so fast it outgrows the healing in the physical, and it begins to deny the physical and actually begins to stunt the physical's ability to grow, because they're not participating in their own care, because they've hypergranulated their spirit, whether it's intentional or it's grown out of control. There's also a tension, I believe, when you're healing physically, trying to remain a healthy gap is what I call it, that while you're still in the healing process, you always have to know where you are, and you have to have faith and hope that you're going to get to where you're trying to get in the healing process. And so you can't try to do things too soon, because there's a reality that you're in, even though you're hoping and you have faith that you're going to continue to heal, even when you're on the healing journey. And I believe there's this gap I talk about, that balancing the spiritual and the reality, that the only reason that we have a faith is because we have a reality. And so I can't live so far in my faith that my reality isn't real, because reality's happening. And when things come to fruition, it can make people feel like their faith has failed them. And you can't live so far in your reality that you have no faith, because then reality becomes just all consuming, all doom and gloom. Whatever your spirituality, whatever your faith is, I always tell people, you have to hold that gap, hold it in a healthy tension. Psalm 23 says, "Yea, though I walk through the valley of the shadow of death, I will fear no evil." Walking through the valley of the shadow of death, a valley always has two hills. And it's best to walk in the middle of the valley and to hold those two hills in tension. Because when we have this hematoma, this grief hematoma, we're always trying to remember that we're trying to engage the unseen. We're trying to engage that which has historically been ignored. So we're trying to assess what's been unaccessed, or diagnose what's been misdiagnosed or ignored. And here's sometimes what happens. This is the diagram that lets us know how wounds and injuries take place. This is a diagram I made. You may have seen some things in your own practices of nursing or in the healthcare environment. But all wounds are injuries, but not all injuries are wounds. Because there's an event, a traumatic event of life, and then there's an injury, a break that occurs, whether it's in the physical or in the spiritual. And then there's a system response. We've been divine, as divinely created human beings, Genesis 2:7 again, forming of the dust of the ground, flesh, breathing the breath of life, the spirit, and humankind became a living soul. There's an automated response built into us in our divine nature, physically and spiritually. So sometimes we get an injury, there's a break, and there's a system response. And in that system response, there's system success in handling that injury. And then there's a healing that occurs, and sometimes there's a scar, and we have wholeness. But sometimes we get that injury from that event, and there's a system response, and there's system failure, or the system's not able to have a successful process of beginning the healing, and a wound will occur. And now that wound can have wound care. And from that wound care, there's a system response. The system is always responding. As we're putting medicine into the bodies, as we're providing spiritual care, we're not just creating healing. We're not just providing healing. We are providing care to create an atmosphere that the system can respond to, and then we're going to see what that system response is. So there becomes this continuation of a cycle of wound care system response to the wound care system response to the wound, that either we're going to continue and that wound is going to not heal, and we're just going to have system failure. We're going to have either it's going to get suppressed or it's going to get buried, or there's going to be a continued degradation of that healthy tissue and that wound, or there's a system response and we're going to have success. And success, like I say, we go success, healing, there's a scar. So being healed and being whole does not mean that we're scarless. So, but that system response, what you'll notice in my diagram is the yellow line with the little brick on it. And what that represents is within healthcare, within the healthcare environment, all of this is taking place for the physical on a continual basis. But very so often when there is a spiritual wound within a person, it stops right there. There's very little, if any, wound care, looking for system responses to that wound care. And this is where historical spiritual wounds are created. And this is where patients begin to not participate in their own care and healing, because when they have these historical spiritual wounds that get created, they have a diminished capacity to be emotionally present in the now, which means listening to nursing advice, listening to doctor's advice, taking the advice and going home and continuing the care that you started. Most times when the doctors and the nurses have given some type of an assessment and diagnosis and a treatment care of plan based on history, they're pretty much saying, based on what we've seen somebody with this injury, this wound, if you do this and take this medicine, we've seen X, Y, and Z success rate. You can see the success signs. So when they're not successful, either they fall into that very low percentage of people who aren't successful, and they just have other issues going on, but you've already assessed some of those. But there's those times you know that everything looks right. And a lot of times it's because they're not participating in their own physical healing fully, because they're not fully emotionally available to do so because of their historical spiritual wounds. Again, this is why I studied wound care, to understand how they assess wounds and how they intensify wounds to create that atmosphere for healing. And this is why I'm big on the identification of the wounds. So I want you to acquire knowledge and tools and skills that can help you to identify these wounds so you can make those referrals. What spiritual wound care professionals do is they either take those referrals or they themselves use knowledge, tools, and skills to identify those wounds, but also to intensify those historical spiritual wounds, that ungrieved grief, in order to promote soul wholeness and healing. And this is done with what I believe is the model that I've developed of spiritual wound care. So let's talk about a case. Gentleman was 56-year-old African-American male, and I met him. He was a wound care patient. He had a left toe amputation, 2 toes amputated on his left foot. He had stubbed his foot. He had diabetes, and they said he didn't come to the hospital for 6 weeks. And by the time he had come, when I met him and talking with the wound care specialist, his toes had become black. He thought that his nails were just going to fall off and they would just regrow. But because of his diabetes and because he was an African-American male who may have had some historical issues with the healthcare system, he didn't come and take care of himself. And so he had the toes amputated. I met him as the wound care therapist was actually packing and unpacking the wound where the amputation was with gauze that was soaked in medicine. And they were showing him and his wife what he needed to do when he would go home. His wounds looked good. They said, you keep packing these over the next few weeks. You're going to continue to see healing. And they expected progress. So I asked him, and his wife, how they were doing. And I recall this was early on in my CP experience as a resident, and the patient gave a laugh, and he said, I'm all right, and he laughed. And I remember hearing about his stubbornness with coming to the ER, but I just made notes of that and made my observation. And 6 months later, I encountered this gentleman in the hospital, in the hallway, in a wheelchair. He remembered me, but I did not immediately recognize him because he was in the hospital this time being seen for right foot gangrene. And I looked, and he had a left leg below the knee amputation that had occurred about 3 months after he got out of the hospital. His wife had become ill, and he begins to share with me about some disappointments and some guilt and grief related to the way that he had been treating his spouse. And I believe that what I missed when he laughed was an emotional underload and avoiding of emotions of that moment and avoiding of emotions from past pains. And now here he is talking to me about his disappointment and his guilt and his grief related to how he treated his spouse. And I remember we talked briefly in the hallway, and he went on, he had to go get assessed for his right foot. 5 months later, I'm going to visit a patient. It's a woman. I don't recognize the name. When I walk into the room, I see her, don't really recognize her, and I look to the side of the bed, and there he is sitting in the wheelchair. His wife is now admitted into the hospital. This is about 11 months after his toe amputation. Now, 5 months after I saw him the last time, his wife is admitted. He's at the bedside, and he's had a below the knee amputation on that right leg that he was getting that assessment for less than 5 months ago. So in the span of 11 months, he's had left toe amputation, left leg below the knee amputation, right foot gangrene, right leg below the knee amputation. I shared some time with them, visited with him and his wife, and then I was leaving, and he asked if he could speak to me privately, and he followed me into the hall, and he began to share with me that he had been incarcerated, and he had some shame from being incarcerated and leaving his wife alone, and how he has been treating her when she stood by his side, and his spouse's fortitude of being with him on his journey, and just the guilt that was weighing on him, and he just couldn't shake it. However, I think he was seeking from me some quick fix, help him get over it, and he wasn't really engaging it. He was trying to avoid it and believed I could just help him with it. And I raise this to make the point that buried wounds may have no pain, but they have power. When he was first encountered in wound care, based on his physical signs, yes, he had diabetes, but the doctors did the wound care, they did the amputation. They expected that if he continued with the treatment regimen, when he went home, he would heal. I assessed after the fact, after doing my assessment of him from a wound care observation, that his issues with his diabetes, his issues with his gangrene, his amputations, were not solely a physical issue, but that his guilt, his shame, his brokenness from his treating of his wife, all of this was continually to manifest in him not taking care of himself physically. So it was continuing to perpetuate the explosion of his diabetes, the explosion of gangrene. He showed up to the emergency room in some pretty bad shape on those occasions, beyond just gangrene, to the point of self-neglect. And you have to ask yourself what causes a person to just neglect themselves to that level. The emotional guilt, the weight. He's not emotionally present, and he doesn't even see himself and doesn't want to care for himself. And that emotion kept manifesting in his physical. And I believe, and I wondered, what may have happened had I caught or assessed that grief underload, that emotional underload, that grief hematoma in that first visit, and pressed in and raised awareness to what I was seeing. Maybe he would have opened up earlier. Maybe he would have gotten some support that he needed spiritually in order to tend to himself physically. And that, to me, is the coming together and the magnetizing of medicine and ministry, that we are caring for the total person and creating a wholeness for their soul in that joint effort of caring. And so I created a bunch of different terminology as I saw the physical wound care therapists would come in and they would prepare the place and they would lay down the different chuck pads and sterilize the area as best they could. And sometimes we do that in the very same way. When we're coming into the room and we're asking, how is your day, or how are you feeling, or have you eaten today, we're really preparing the space. We're not just coming in. We've got to assess the wound or see where you are or how you're doing today. Are you ready for some wound care today if we know you have a wound? So there's a translation of how they prepare the space and then how we prepare the space. Sometimes they would use distraction therapy. They might ask me to have a conversation with the patient to distract them from the pain that the physical wound care therapist was causing in their treatment and tending of the wound. Or they might turn on the TV for the patient so the patient could watch their favorite show while they tended to the wound. And sometimes we have to do that spiritually too. We may distract you for a moment. We may watch a TV show with you so that we can do some laughs or talk to something that might create a space that we can come back and we can talk about and we can tend on those wounds. There's a closeness that they had in caring for those wounds, the touching and the washing and the wiping, the debriding that they would do with those wounds. And I believe that spiritual wound care is very similar. That there's a closeness, that there is an emotional and a spiritual touch, that there is a debriding that I think is also very similar to the evacuating of the hematoma, the assessing of the wound, what's viable, what's not viable. I've always asked this question and I still don't have the answer yet. But if someone has a gangrenous spirit, can that be amputated? Because when we have gangrenous tissue, we amputate it, because we know that the gangrenous tissue will continue to degrade and infect the healthy tissue. So what happens if someone ends up with a portion of their spirit being gangrenous from holding in these emotional wounds? I'm modeling the physical care and trying to develop this model of spiritual wound care. Physically, they would assess these wounds for odor and color and feel and certain things like biofilm and the necrotic tissue, the slough of the wound, the eschar, all these different things they would do. And the one thing I really loved that they would do is that when they were going in and they were debriding that wound and they were pulling on tissue, if there was resistance, they didn't just rip it off. If there was connectivity to healthy tissue below, you didn't want the wound to bleed. You didn't rip it off. There was a delicacy, there was a touching, but there was a pull. There was a resistance. And sometimes when I'm pushing in on patients and I'm asking how they're feeling and there's a resistance, maybe I pull back. Maybe they're not ready. Maybe I haven't asked the right questions. Maybe I'm not using the right medicine. We have a variety of medicines because I paid attention to what the physical wound care therapists were using. They had a variety of different medicines that they would use on the wounds to provide the care. And it is the same and very similar in the spiritual wound care practice that I'm developing. So we're doing all of this because we're trying to promote an atmosphere of healing. In spiritual care, it's the fostering of healthy grieving in order to promote soul wholeness. So what is this healing? So healing it's a double word. It has a noun and an adjective property. So from a noun perspective, it's the process of making or becoming sound or healthy. It's a gift of healing. An adjective is the actual tending to heal. It's therapeutic, a healing experience, or the healing process. So in one, there's a state of being, a condition, and another one, there is a process. And we're looking at healing in that the tradition, I've looked at it theologically, and when I looked from the Christian perspective and studied in the Bible, there are you read the word healing, but in the New Testament, in the Greek, there are several Greek words that are translated into the word healing that we read in English. One of those words is hagios, which actually means to be whole. So, and when he had looked around at them, he said to the man, stretch out your hand. And he stretched out his hand, and he was restored as whole as the others. This hagios is a making whole healing. Then there's katarazao, a cleansing. In the Gospel of Luke, he said, so when he saw them, he said to them, go and show yourselves to the priest. And so it was that as they went, they were cleansed. They were healed, katarazao, a cleansing. And then there's ethiopeo, which is translated to the English word of therapy. In Luke, it says, and he said to them, you will surely say this proverb to me, physician, heal yourself. Heal, therapeo. So we have hagios, to be made whole. We have katarazao, a cleansing out. And we have therapeo, a therapy. All of these words healing. But we can also identify an action. Hagios is really about making whole, some kind of a hygienic cleansing. Katarazao, a cleaning, a releasing, a getting something out. Crying is very cathartic. Katarazao, we're cleaning. And therapeo, a therapy. We therapy, whether it's massage therapy or other kind of therapies. So the healing that occurs from these, we attribute them to things that we can see done in the natural. But then there's the fourth healing word, iomani. Identification, intensification, iomani, I3. Iomani is the Greek word translated for healing. And it, also in the Gospel of Luke, it says, and one of them, when he saw that he was healed, returned and with a loud voice glorified God. This word iomani, found in the New Testament, is always found in a form that is called aorist passive, which means this: you cannot find or identify any human intervention that explains the healing. This is a divine healing that has occurred. This is not comforted, this is not cleansed, this is not therapeutic, but it is a physical infirmity that is reversed or removed without explanation of human intervention. Now, it is to be said, the Gospel of Luke, to be said, is written by a doctor. Luke is a doctor. And he writes and uses this word iomani more than any other writer of the New Testament or the Gospel. This word iomani is found 4 times in Matthew, 1 time in Mark, 3 times in John, and 3 times in Hebrews and James and Peter. But it is found 17 times in the writings of Luke, 12 times in the Gospel of Luke, and 5 times in the book of Acts. Luke, being a doctor, saw something very divine in his methodology, his tending, his caring for people, and the healing that occurred. And even though he may have done treatment, the healing couldn't really necessarily just be attributed to one thing. And there are very often times where we do provide medicine and we expect and anticipate the body to do certain things with that medicine. And sometimes it happens and sometimes it doesn't. And when it doesn't, and sometimes when healing still occurs, we may look and say that it's therapy, but sometimes it may be iomani. And so in the spirit, I'm really trying to help provide things, tools and information and care to patients that will help bring about an iomani healing. Therapy is good. Katarazao is good. Hagios is good. But iomani is a reversal, and it brings about a wholeness that the other 3 don't. Let me show you what I'm talking about. In this case, I call it all in. This man, CC, a 46-year-old Hispanic male, he was a truck driver with some children. He'd been all over the country. He had diabetes and got bitten on his foot. And when he was bitten on his foot, he was taking a shower, and the spider bite on his foot, that he didn't know because of the diabetes. He washed his foot and the bottom of his foot came off to the bone. He went to a hospital, didn't have insurance. They wrapped his foot and put him on the corner. He showed up at our hospital. They recommended amputation, but he was all in. Give me wound care. Tend to my foot. And they were tending his foot. They were debriding his foot. They were providing ointment on his foot. They were promoting healthy tissue generation and regrowth. He was all in. And when I visited him, I observed the debridement. I observed the pain that he was being inflicted during this care. But my conversation with him was about his wound, but it was also about his family. And him telling me about him being this long-haul truck driver and the importance of feet for his job. He requested prayer from me, and we prayed and we engaged in grief, and he said that his spirit was elevated. I saw him on another occasion observe the wound care, and he talked to me about being sad and being lonely, and he was weepy and hadn't seen his children. They lived in another state. And we explored his emotions, and we explored my companionship that was being provided for him, and he was lifted. And after this visit, the physical wound care therapist came to me a few days later, and she brought me a picture because he didn't know if I would ever see him again. And this patient drew a picture of me. And he gave it to me. And this picture, I know, that's me. He was evacuating his grief hematoma in his drawing to promote his own healing and stave off his infection. All I did was create the atmosphere in which healing could occur by just being present and being companion and listening. And then he was able to engage his own emotions and evacuate his hematoma in artwork. But I did go back and see him again. I saw him on the day that he was being discharged home. He was in good spirits. His foot tissue had grown back almost around his entire bone on his foot. He was going to go home, continue wound care from outpatient, but he was so lifted. He prayed for me, and he prayed for the staff, and he prayed for other patients. And he thanked God for food. He thanked God for friendship. And with tears in his eyes, he said to me, "I love you, friend." And I said back to him, "I love you too." You see, we cannot create, operate, or tend to the physical wounds and take no responsibility for the soul which we are impacting. When we tend to that physical, but we ignore that spiritual, that's when his loneliness, his thinking about his not being able to potentially drive truck again, could have been buried and become a historical spiritual wound. But I partnered with the physical care as they continued to do what they could do for him physically. I partnered with him in the spiritual, and he was so invested and so all in and stayed all in. And this is what led to him continuing his healing journey and finding his wholeness through his situation. So let's look at CC through the tool and the lens of the flat. We'll be right back. CC was all in. Now CC's flat score probably would have been pretty consistent through all of his visits. So let's just look at an overall perspective of how I assessed his grief and how it fits into the flat tool. When he came in, from beginning to end, he had a very healthy gap, speaking of his faith and his family, the reality of his illness with his foot, and his hope for healing. So he had a healthy gap. And he was grieving not being with his family. He was having a very healthy Thursday experience, embracing the grief of his situation, present and past. He told me several times, emotionally, he felt hurt. He also felt very hopeful. He was sad There were times that he shared tears with me. He was optimistic, and he would give good detail about his emotions and being good. He also did feel alone because he wasn't with his family. His language, he would talk about and he would talk about it being his emotions. He would talk about himself saying, I am. And every now and then he would say they are. And so we'll mark that as well. He was very focused on self. Internally, he was focused on his emotions. He even accepted responsibility, not allowing anyone to do anything to him that he didn't want to have done. And he really focused on the human experience. His tone, tense, and time, full of hope, full of optimism, and he was living in the present. I'll never forget CC. Let's see what his score is. CC came in at a very high, healthy 11.25. And if you look at that, his feeling lane is huge. His focus is very high. His faith is very high. He's very healthily grieving. He's very healthily engaged. And I believe it is because of his healthy grief engagement that he is able to hold on to hope while also healthily managing his care and speaking with the nurses and the doctors and the wound care therapists and getting the treatment that he wanted in spite of what everybody else wanted to do with him. He was able to make healthy decisions because he was healthily engaged in his grief. So with CC, I noticed a lot of intensification in his wound and the tools that they were using to care for his woundedness. They were using water and ultrasound machines. They were developing new muscle because they were talking about that new muscle is different. There's new skin tissue versus scar tissue. They would use silver nitrate so that the wound wouldn't grow too fast. Sometimes we want healing to occur too fast, but there's a process. So they would actually use a medication to keep things from growing too fast and creating that hypergranulated tissue. And sometimes in the spirit, we need to help people kind of sit in their situations and not have things grow and rush too fast. They would cauterize the skin to keep it from growing too fast. They would do a lot of things. I heard a lot of things from patients. I heard good news and bad news. Trying to save things, but the infection might have been to the bone. I observed, the work that was seen. It was a help to me in what I do with the unseen. Sometimes the things that we would want the patient to do, the patient wouldn't want to do. They would want a patient to wear a stocking, but they didn't want to wear it because it was too painful. Or we were going to do scalpel removal, and they would always ask for permission before just cutting on a patient. Things that even in spiritual care we often take for granted or can't take for granted, that we have to ask permission for everything we do. We don't just pray because we're the chaplain. We pray because we ask for permission to pray. We pray because they ask for us to pray. I also discovered that wounds heal best at body temperature. And you can imagine that our emotions actually change our body temperature when we get angry. We're cool, calm, and collected. So as we tend to their spiritual needs and help them have a healthy emotional engagement, it can actually help promote an atmosphere for physical healing by helping them maintain healthy body temperature. So in the spiritual, I use a lot of tools that I've translated and modeled after what they use in the physical to intensify their care. These are just things. We use scripture. I use song. I use my own tears when they come. I just let them flow. I talk about their soul and not just their physical or their spiritual being. You know, there's a lot of different tools that we can use. Storytelling, we use their faith tradition. We use a lot of different things to help them to engage in the present moment, to help them engage in all of their emotional being. But there's a multi-use and a multifacetedness to this, because it's not cookie cutter, it's not pigeonholed. Every patient doesn't fit into the same bucket. Every patient doesn't get the same thing. But we have to go in and identify and assess what wounds do they have, and then we determine in the intensification process what medicines, what tools, what knowledge are we going to give them, what understanding are we going to try to help them realize so that they can continue to participate in their own care. What kind of things are we going to give them for when they go home to continue tending their own spiritual wounds, and even do, as they do in physical care, their own dressing changes. In the physical, they may give silver nitrate or lollipops or gauze or packing strips to tend to wounds. In the spiritual, we may give daily breads or sacred text or devotionals or books or journals or lectio divinos or prayer conversations. Sometimes I've given the I am tune, and sometimes I've even written life stories with patients, and so that they can take their own story home and read their own life story. They sometimes have never had anybody to listen to them, so they haven't told their story, and I take their story, write it down for them so that they are able to be strengthened by listening to their own story. So what are the takeaways from today's session? That we want to get to the point of intensification after we've done the identification of those wounds. Just like in physical wound care, they identify and then they intensify through a wound care process. We want to intensify through a spiritual wound care process by getting referrals and providing that care. We don't want people to be suffering in silence. We don't want people to bury their wounds and have their wounds manifest through the physical in other ways that they may have been able to participate in their own physical healing if they may have received the spiritual, emotional support that was needed for them to be presently available. We don't want to take away that we're really modeling language here. You will see a lot of language used, especially by me, and as I begin to share this training and I begin to hopefully train other spiritual care people, uses of words like the grief hematoma or an emotional underload or a hypergranulated spirit, that I'm trying to mirror language so that as we talk about the spiritual condition of a patient or a family member, that it may resonate with the interdisciplinary team with language that they are familiar with that's been translated into a spiritual model and usage. And lastly, we want patients to be all in. We want patients to have a healthy balance of whatever their faith and the reality of it, and hold on and be all in regardless of the outcome. We can have consistent outcomes when we're fully vested emotionally and spiritually, even if the wound doesn't heal, even if there is wound degradation versus wound healing promotion that occurs. We will have consistency and outcome as a whole when patients are able to be fully invested in their care, because they're not receiving care for just half of who they are, but they're receiving care for the whole of who they are. All right. We'll see you in the next session. Be blessed.